I will call this meeting to order. We will start with the consent agenda. All the following items which concern reports and items of a routine nature normally approved at AHA meetings will be approved by one vote unless any trustee desires to have a separate vote on any or all these items. The consent agenda consists of a discussion, consideration, and action on the following items. Minutes of the special trustee meeting May 22nd, 2023, and a check report May 9th, 2023 through June 8th, 2023.
I move we approve the consent agenda as presented. Second.
I have a motion by Dr. Brown, a second by Jay Randalls to approve the consent agenda as it was presented. Roll call vote, please.
Gaspard?
Yes.
Hannaford?
Yes.
Randalls?
Yes.
Brown?
Yes.
Bowman?
Yes.
All right, I'm going to change things up just real quick. We have with us tonight Darlene Bainbridge from SQSS, and she is going to do a quality presentation for us. So, Darlene, I will turn the floor over to you.
Thank you very much. So, just to give you a little bit of background on me so you know what brings me to your hospital. I've been coming out here almost 10 years, I think it is.
I was going to ask you how long it had been.
So it'll be 10 years in September. The state has a grant that brings me out here to work with all the critical access hospitals in Oklahoma on survival strategies, particularly in the area of quality. I first started doing healthcare quality and risk management in 1980. When it first became a requirement to get through a joint commission survey. And I've had lots of different positions. I worked for a med mal company for a number of years where my job was to help hospitals and doctors stop getting sued so much. And I was the director for that hospital. I coordinated one of the first Robert Wood Johnson Foundation grants in the country for quality. And then I actually became the CEO for one of the first 3 critical access hospitals in the country way back during the demonstration project. And that's what prompts me to do so much work with the critical access hospitals. It's still hard to find consultants that really understand us and our payment model and our dynamics. And I was put in there by our state health department to save the hospital because it was on its way down. And we were so successful in doing that, I ended up as the lead consultant on a federally funded project with over 100 critical access hospitals in it. So most of my career for the last 20 years has been spent working with critical access hospitals. And so we are critical to the survival of the healthcare system at large. And I know there's a lot of people out there that don't understand what would happen if all these smaller hospitals all of a sudden closed up. But it would have a huge impact on the healthcare system. And I think COVID was a great example of that because I had, including your hospital, I had hospitals all of a sudden calling me and they'd say, our health departments are telling us we have to take ventilator patients. Or we have to do this, or we have to do that. And they said, can we do that? I says, well, I suppose if they tell you, you can. And you feel comfortable doing it. But see, historically, we've been kind of perceived to be Band-Aid stations. And one of the things I've learned over the years is that there's a level of compassion and caring and attention to detail that can exist in our smaller hospitals, sometimes much easier than it can exist in our bigger hospitals. And it's nothing against the bigger hospitals, it's just the dynamics they deal with, all right? And so when I worked for the med mal company, we used to joke, those of us that went out and worked with all the hospitals, we used to joke we were going to have it tattooed on our chest that unless we needed high-tech intervention, to never take us to a hospital with more than 250 beds. Because the dynamics of quality changed in those organizations. And so anyhow, I think it's really important our small hospitals survive. Your hospital deserves to be complimented because I started coming here to work a lot with your hospital when you had a very bad Medicare survey. And Candace contacted me and said, the state said you can help us. And so I've been coming here a lot since then, and I've watched this hospital evolve. I have watched your attention to detail and quality evolve. You just had a DMV survey with only 4 minor deficiencies, and that is very unheard of right now in this environment post-COVID. Many of our hospitals lost control of their quality programs during COVID because you could only spread your staff so thin. But a lot of our hospitals that are using SQSS did very well throughout COVID, and they actually came out of the COVID with not nearly the survey problems that some of the other hospitals who are still doing it manually did. So you did extremely well on your DMV survey. You just had a med-mal survey. I happened to be here the day she came and got to visit with her, and you folks did extremely well on that also. And she was very complimentary. So you should be very proud of what your hospital delivers today in spite of all the stresses that we have working against us, and what the hospital has accomplished. I think some of the things that I just wanted to mention tonight are things that I think are going to be important for us going forward, because this environment's only going to get uglier, I think. It's not going to get better anytime soon. The payers are trying to figure out how to make their bottom lines look better by reducing what they're paying our healthcare providers. And so every day there seems to be a conversation about some new whittling away at the way at what we get paid. You know, I've been in this long enough that I remember the days when we got paid very, very well. We even got paid to fix all our mistakes. And the cash flow just flowed into our buildings. And then we started to see the cash flow decline for our organizations. And I think this is the ugliest time I've ever seen for hospitals as far as strategies for surviving, just because of the dynamics, the way they played out. One of the things Candace and I frequently talk about is the fact that it's extremely important right now that we move to a more business-oriented quality model in healthcare rather than the regulatory model and the compliance model that we have been dealing with for the last 40 years. Simply passing a survey is not enough anymore. When the surveyors walk in these buildings, they are only looking at 10% of what could hurt us and hurt our patients. And so the strength of our quality programs are, I thought I shut it off. Oh, sorry, I thought I shut that off, I apologize. So the strength of our quality programs lives in controlling it all. Anything that can hurt our patients, hurt our relationship with our patients, and hurt us. And so it's extremely important right now that we be migrating in a direction of a quality model that is more like what other industries use, all right? One where quality is about everything and anything that can hurt us, not just what it takes to pass a survey. I think there's a lot of things we need to rethink as we move forward in this current environment. So for example, we've got to be very careful where we look to save money. Historically in healthcare, every time we get ourselves in a financial bind, we lay off a bunch of nurses. I mean, they've always been the biggest department in the hospital, they've always carried the biggest salary costs, and so it just always seemed to be a good place to cut. And right now it's a very dangerous place for us to cut because they are the revenue generators in the hospitals. Without them and the physicians, we would have no money coming in. And so it's extremely important that we protect, protect that piece of our organizations. I have a hospital that I've just recently been asked to work with. They made a whole bunch of clinical staffing cuts during COVID, and now they cannot hire nurses. They're strongly dependent on agency nurses, which just break us financially. And they're trying to put together a strategy on how they're going to rebuild their nursing department. And it's a hard climb these days. Nurses are very versatile people. The drug companies love to hire them. The insurance companies love to hire them. The malpractice companies like to hire them. Everybody likes to hire our nurses because they're skilled, versatile people. And we need to recognize the competition that lives out there for them. And most of those companies offer them an easier life than we can give them. It's tough being a nurse these days. EHR should have been tools that made the lives of our physicians and our nurses much better, and that did not happen. And most nurses will attest, and most studies are now showing that EHRs are a major reason nurses are leaving the profession. And so we just need to, we need to step back now and recognize that that's not where we're going to save money going forward. We actually probably will cost ourselves money if we cut there. We need to start focusing more on using our quality programs to manage and control all those areas in our organizations where we can have losses and wasteful costs. It's like one of the things you folks have done here is you have gotten rid of virtually all your committee meetings and you've gone to what I call a super committee structure. Because it's the same 8 people sitting at every committee meeting. So why just keep making them come in this room and sit down and discuss the same issues over and over again? But see, committees were an easy way for us to create the perception for surveyors and regulators that we were doing something. See, in the era when I became a quality director, it was about busy work. That was my job. When the surveyors walked in, my job was to make sure I could dazzle them with how many new forms we'd created since the last time they'd been there, and how many steps we'd added to our procedures, and how many in-services we had had, and how many of this, and how many of that, how many memos we'd sent out to the staff reminding them to do their jobs. And the difference was we had the money and we had the manpower for that model then. We don't have that now. Everything's about efficiency, effectiveness, and getting it right the first time and hanging on to it. Because one of the greatest threats that lives in healthcare right now is we continue to do too many things where we practice to what the business world calls the 100 and the 110-100 rule. So we fix too many things after they're a problem, after the fact. And so we spend to the 100. And in healthcare, that 100 is typically 10,000, 100,000, a million, or more, right? They just published an article. They estimate that the average successful cybersecurity attack in healthcare costs a hospital about $7 million. Now, for a hospital this size, that figure wouldn't be that big, but your revenue streams aren't that big either. So if you take all hospitals in the country, the big ones, the Mayos, the Cleveland Clinics, Share, St. Anthony's, everybody, the average cost of a successful cybersecurity attack right now is estimated about a $7 million loss to a hospital. So all these things add up. You know, right now they're saying just one medication error in a hospital, even if there's no harm to the patient, and you don't have to do anything for that patient, because it was a simple, what they call a simple medication error, the average cost is about $5,800. And that's because of all the administrative costs that now have to go into filing the incident report, doing the investigation, creating the documentation we're going to need for the surveyors and the regulators and all that stuff. And so there's great reason for us right now to run with the strongest quality programs we can to control all those kinds of costs. The average cost of one infection right now is estimated to be somewhere between $8,000 and to a hospital. And so think about how much money that is. If all of a sudden you start taking these 3 or 4 dozen things that can generate those kinds of costs for us, and we decide whether they are not going to happen in our buildings. Okay? So anyhow, it's learning how to practice to the one, which you folks are getting so good at. It's like when Candace didn't happen to be here for the survey. And so Regina called me and she said, will you sit in and listen in on the summation conference with the surveyors so that you understand what they're telling us we have to work on? Because I've always helped you guys with your surveys. So I'm sitting there listening and I kept thinking to myself, so when are we going to get to the deficiencies? Because they just kept talking about how great you guys did, how impressed they were with your quality program and your use of SQSS. And so then we got to the deficiencies, and there were 4 very, very minor deficiencies that had no potential for patient harm at all. They were just minor administrative things in the building. Like you had a task in SQSS for checking all your fire doors like you're supposed to. They wanted us to turn that into a checklist so they could see us checking off that each of the items we're supposed to look at on the fire door. But it was 4 simple things like that. But you know why that's important? Because you guys could just keep moving as a hospital and nobody had to stop, so we could spend to the 100 on big corrective action plans. Okay? So it's, making sure we're making smart choices now as far as how we save money. Because we are an industry that has historically made some pretty foolish choices about how we save money, because we come out of an era where we were drowning in money. So we didn't necessarily step back and have those conversations that said, well, so what will the long-term impact of this choice be if we go down this road? And now we have to have those conversations, because I don't think we're not going to see the handouts we've seen in the past. If we do see handouts, they're not going to be big enough to have much of an impact on our buildings at all. The economy of the country's just not going to allow for it, and which means we just have to get a whole lot more business smart about how we do all this stuff. And in any other industry, that's the job of the quality program. The job of the quality program is to protect who we are. Protect our money, protect our people, protect our customers, protect our relationships, and that's where we now need to take our quality programs. One of the next big steps for you folks is going to be to really much more aggressively bring all your financial pieces of the organization into the quality program. You are at that point in your DMV survey process where they will begin to look at that. The last 2 surveys you had with them, they alluded to it, but they didn't actually go there. So because in DMV, it came out of the rest of the world of business. And so they always recognize that how we manage the money is as important as how we manage anything else. But when they brought it into healthcare, the DMV survey into healthcare, CMS was driving the bus, and CMS's focus has always been on the clinical side of our organizations, not on the financial side. So the model DMV put together for the survey process for hospitals was they would focus very heavily on the clinical side, and then they would migrate into the financial side of the organizations. And you folks are at the point now where I anticipate this next survey, they will focus much more heavily on, just how are we managing the money side of the business. So, what do our claim denials look like? How much money are we losing that we shouldn't be losing because of the mess the general finances are in healthcare. It's a nightmare out there. And so that was one of the things we talked about while I was here today, is that when I come back the next time, that we really need to start looking at that. I did meet with Kelsey today. I don't know if has the board met Kelsey?
I don't think they've met her, but we did have a finance meeting today, and I briefly talked about what I sent her role transition to.
Okay. She's done a lot of very nice preliminary steps, building stuff in SQSS that helps us track things that impact the money, the clinical side of the organization that impacts the money. I've been very impressed with how fast she learns and how and conscientious she is about what she does. So she and I actually had some conversation today about what, she asked me what I thought that, she says, I hear you talked about that, so what's that next step look like? And so we talked a little bit about that. And that's the next place for your hospital to go with the SQSS and with your quality program. Just so you understand a little bit about SQSS, I started building SQSS after I did that big federal project with over 100 hospitals in it. Because when I became the CEO for the hospital I was at, it took me maybe 8 weeks to figure out most everything I had been taught in the 20 years prior to that as a quality and risk management professional was not going to help me save that hospital. It cost too much, it was too hard on my staff, took too many resources away from patient care. It was a lot of bureaucratic busy work. And I needed something lean and mean that was going to help us bring back a community that the hospital had lost, and to help us control for the money I didn't have. And so anyhow, and so I learned a lot about a different quality model while I was CEO. And then when I became the lead consultant for that federal project, I had 100 hospitals that had all the same struggles, but not the quality background I had. And it was 10 years of a lot of stress for me, trying to get them all to a place where we could save them all, make them all financially healthier. But I learned a lot, and the second we were done with that project, I started building SQSS. Because here's the reality, folks. Right now in healthcare, we cannot manually manage all the demands we have on us. Candace and I have this conversation all the time. We can't. The average 100-bed hospital is estimated to have 150,000 safety activities alone that it has to manage. That doesn't even count the clinical stuff and the patient satisfaction stuff and all the stuff that impacts us every day.
How many tasks did we see that we had today?
We went in and looked later, and you had just over 50,000. And you're a critical access hospital. Think about that. License renewals, TB tests, respirator fit tests, all the stuff we have to do to make sure this building is safe, the fire drills, and checking all the fire signs. And, I mean, the number is enormous. And unless we can find a smarter way to manage all that stuff, we're never going to find the time we need for our patients, because the government keeps writing more regulations for this other kind of stuff. And so your hospital right now is probably one of our best performers in SQSS. You use all pieces that are in SQSS, and there's a lot of them. Contract management, credentialing management, use all of it now. But the idea is you use a computer system to help you manage all this stuff. So people like Candace and Regina and your nurses and your doctors have more time to take care of the patients and to do things that we need them to be doing to help our hospitals survive in a very trying time. And so that's why our hospitals did so well coming out of COVID, because like we have one hospital, they were surveyed 3 days after the CMS lifted the moratorium on surveys for the hospitals. The surveyors walked in 3 days after that moratorium got lifted. And they came out of the survey with only 3 deficiencies. And they said the surveyors kept walking around the building going, I can't believe it. we can't believe you guys don't have more deficiencies. They actually stayed an extra day just to make sure they didn't miss anything. But, like the DON said to me at that hospital, it was because every day SQSS was working with the staff to make sure the crash cards were getting checked and the temperature checks were getting done and all this stuff was getting done while I'm over here making sure our COVID patients are getting taken care of. She says, because I couldn't have done both. So if the COVID patients had to take priority, all this other stuff would have fallen apart. And see, that's what we need to get to now. And your hospital has done a remarkable job making that happen. We were going through a bunch of your reports today, we went through your quality minutes today, and you know, they just, it's just phenomenal. It was funny because after your last survey, and I sat in and listened, and then I hung up, and pretty soon my phone rang, and it was Regina, Mark, Amber, Coco, and a couple of other people. And they said, well, that wasn't so bad. They said, and we already got the corrective action plans figured out. I said, okay. I said, have the surveyors left yet? And they said, they just went out the door. But see, that's where we need to get to. This quality stuff's important, but it should not be consuming so much time that it takes us away from why we really exist. And that is to deliver patient care. But the only way that's going to happen for us is if we start really aggressively using tools like SQSS. So, your hospital also uses SQSS. And they do a very nice job also. A lot of the St. Anthony hospitals are some of our better users of SQSS. So anyhow, but are there questions I can answer for any of you?
Did you mention what SQSS stands for?
Oh, I'm sorry. Strategic Quality Support System. So, and what it does for the smaller hospitals is it allows you to manage lots of things in one place. That was one of the things I learned when I was CEO. Was people would come in my office because they knew I had a quality background. They'd come in my office and they'd say, oh, I need to buy this software package. And I'd say, well, I already bought one like that. And they'd say, oh, but this one's different. And what I really learned was, every time I signed one of those checks, 80% of the check went to pay for an engine I already had, over and over and over again. Because I was paying for the same engine to get a credentialing software package where there was some 20% tacked on top of it that made it a credentialing package, or an HR package, or a contract management package, or whatever. And I used to sit in my office and I'd think, now what can I do with all that money if I only had to pay for the engine once? And how much easier would it make it on my staff if they only had to know one system? And how much easier would it make it on me and my quality professionals if we could go into one system and find all the quality data for the whole building in that one place? And that's why SQSS is built the way it is. We have 23 major areas of risk in healthcare right now we're trying to manage, from patient safety to environmental safety to contract management to infection control and prevention to cybersecurity to environmental security, and it's just, you know, we got to get smarter about how we do it. And you can manage all 23 of them in SQSS.
How many hospitals do you have?
Right now we're up to about 160, and probably 90% of them are critical access hospitals.
It allows us, so we have Coco in name is our quality director, but Coco runs the lab. I mean, she's got a full-time job. We had to have somebody in name be our quality director, but truly, we save a full nurse's salary that would be our quality director by having this software system.
Yeah, and you probably have saved,
We got rid of IT, we got rid of maintenance, we gained a policy and procedure management software, credentialing, yeah, I mean, all of those things would be, like she said, separate subscriptions to a service to provide that. And like I was telling, we did a demo today for a hospital, and I said, if our hospital blows away tonight, burns down, between our EHR coming, will be cloud-based hosted, and this, we would have all of our policies and procedures. We would have everything we needed to set up a managed camp tent and carry on with business, which is pretty phenomenal.
Yeah, we have one hospital up in Vermont. They have just consolidated the last of their software in SQSS. And the CFO called me and he said, I just want you to know, because it's just in licensing fees, I've saved the hospital well over $100,000. He said, but he says, and then if you add all the efficiencies on top of that I've gained, he says the savings is huge. And and so that's where we start adding up the money. Because there's no big pots of money left out there for us to chase. Even the big hospitals are struggling to find a new pot of money to chase. And so it's now all about cost and loss management. If we're going to make our bottom lines work, that's where our efforts have to live. We have to chase what revenues we can. It's like the conversation we were just having before this meeting started, and some of the things you're going to try down at OP. And I think they're great ideas because they'll help you bring in some revenues, but it's still about loss and cost management.
If we're not Alva, people don't know where we are. So those things, Moline or something else, like, no, Keen, it's flashing line.
Yeah.
No restaurants,
Right.
no gas stations, joking.
So, but they have a great little hospital, just like you guys have. So, anyhow, there's new features coming out in SQSS, and so we worked on the plans for implementing those today. Where next year we will be bringing out an employee evaluation tool that will automatically draw an employee's performance data out of SQSS and auto-populate their evaluations so we can do better performance-based evaluations. We have a survey tool that you folks presently use and OKEEN uses that will, by the end of this year, actually be part of SQSS. It's a separate tool now. It interfaces with SQSS, but we've had lots of requests to just make it part of SQSS. So it has the same look and feel as SQSS. It's easier for us to build our own patient satisfaction surveys and things because I think we're going to have to do a lot more aggressive type of patient satisfaction going forward. We have to really understand what's going to make a patient decide whether they will come here or they will go someplace else. And HCAP surveys, as well intentioned as they were from the federal government, are never going to help us do that. And that was something I learned being CEO of my hospital. When I got there, folks, we were averaging 1 patient a day on the med-surg unit, 3 patients a day in the ER. And my rehab staff thought their job was to play canasta, because that's all they had to do. And when I left there after 5 years, we were averaging 23 patients a day on our med-surg unit, a little over 50 patients a day in the ER, and I had gone from 1.5 rehab employees to 18. I owned every rehab contract in the 3-county region. And the only strategic plan we had in place was to build a reputation for quality that was so knock your socks off that patients would drive to our building to get it. And so, see, that's what we're good at in the small hospitals. We can be really, really good at that, but it's something different than the way we've traditionally done this stuff in the past. Okay? So all hospitals I work with, I encourage them very strongly. Very strong control of your environment, your quality, and your messaging. Because see, here's the other thing and you folks all know this better than I do. When you are in small town America, the town knows they own the hospital. I'm sorry, I thought I to shut that off. But it's my husband calling to check on me. He worries about me driving around out here by myself. Anyhow, what was I saying?
That's a small thing.
Oh, small town America, okay? And when they know they own you as a community hospital, and no matter how hard you try, you can't keep stuff. Yeah, I shut it off. Now let's see, make sure I do it right this time. Okay, and so they pay a lot of attention to the hospital. And I remember one time, one of my best friends at the time, who was also a hospital CEO, but he was a CEO of a very large hospital down towards New York City. He and his wife came out to spend the weekend with us, and we made the mistake of going to Walmart. And after like an hour-long excursion to Walmart, he says, "Everybody knows who you are." I said, "I know, that's why I get dressed up to come to Walmart." He says, "I have employees who don't know who I am." But see, that's small town America. But so we have to be very conscious of the stories, the experiences the patients have, and the stories that flow out of our buildings. Because when I first became the CEO of the hospital, after the state asked me to go there, I was downtown talking to a bunch of people, and they were telling me about this bad baby case that had happened at the hospital. And I kept thinking to myself, wow, that must have been a while ago, because we don't do OB anymore. And so I finally said, well, when did that happen? And they all thought for a few minutes, and one of them says, oh, I don't know, that must have been back around 1975. And I went in there in 1996. And see, they were still talking about it. Or one of the experiences I had shortly after I got there was, I discovered people in town were calling the hospital to see who was on call in the ER, which doctor was on call, so they could decide if they were coming to our ER or they were going to drive 25 miles down the interstate to the next hospital. And when I asked why, they said, well, sometimes he can be kind of grumpy, and so they've just learned they don't want to come if he's here. Well, you know what, so we worked that out. We got it all fixed. But you know what? These are the kinds of things that haunt our small hospitals all the time. And we just have to be conscious of them, and we have to be in control of them, because they can decide whether or not a patient will come here for care or they will go someplace else for care. And before I left there, we had built such a strong reputation for our quality that I actually had to call the health department and get them involved, because I had patients insisting that the ambulances bypass the larger hospital we transferred to bring them to my ER. And one night I got called, stabbed to the ER. And of course, when you're a CEO, the color just drains right out of your face when they do that. I go running down there, and this gentleman was on the stretcher, and he had had a massive heart attack. And the ambulance drove past that other hospital and brought him to us. And I looked at him and I said, did you not know you were having a heart attack? You could have died getting here. And he looks at me and he says, I know, but the word on the street is I came here, I get pain medication faster, and you could bypass their ER and get me admitted directly to the ICU. And I said, it's not worth dying for. But we ended up having to get the health department involved, because I needed them to come in and address what was going on in that ER, so that I wasn't having patients endanger their lives getting to my ER. But I said to the health department, I am not changing my position on quality. Every person who comes here will get the very best quality we can deliver. It's your job to make sure they don't bypass that ER to come to mind. And they did go in there and address it. But see, this is what we're capable of in our smaller hospitals. We're not band-aid stations. And we can give some of the most caring care there is. And we just need to do a better job controlling it and marketing it so that these hospitals will survive as the environment gets uglier.
Well, thank you, Caroline, we appreciate it. Anybody have any questions?
You said the next phase or something that we need to look into is the cash side?
Yes, you know, so SQSS is built to help us monitor things like denials. I mean, you guys have companies you're working with, you have you have people you're working with, but the whole idea is if it's all that data is in one place, it's easier for Candace to monitor it and know what's going on everywhere in the building, including on the money side. The money side of our buildings are having a tough time right now. The payers are throwing out rules faster than I change my outfits, and that's fairly often. And it's a tough time for us right now. There's so much busy work in the way in our billing processes. There's so many players in our billing processes. And we just have to have a better sense of what the quality side of our billing processes look like. You know, it's like, one of the things we talked about today was, there's a feature in SQSS called Just Do It's. And so if you have an issue, and Candace is known in the building as the Just Do It Queen. Because she's throwing out Just Do It's all the time to the staff. Because the idea is, I would push a Just Do It out to somebody that I need something from, and then I don't have to think about it anymore. And the system will monitor to make sure it gets taken care of. And once they've taken care of it and documented their corrective action plan in the system will notify me back that it's been taken care of, and I can go in and read what they wrote while I'm off doing other stuff, okay? And it's a great efficiency tool. We have a lot of our hospitals now where the billers, when they go to drop a bill, and they can't drop a bill because they're missing a piece of information from lab or radiology or someplace else in the building, they will send Just Do It's to those departments. Historically, we picked up the phone and called them and said, I need the diagnosis on Mr. So-and-so's lab work or whatever. They send Just Do It's, and then the CFOs are trending the Just Do It's. So I walked into one hospital one day and the CFO said to me, here, I'll show you something. He opens up SQSS and he said, see that? 32 times last quarter we had to send Just Do It to the lab for that piece of information. It's now a QI initiative for them to fix the systems issue that causes it so it stops happening. See, we used to be an industry that could fix our issues one event at a time, over and over and over again. We just kept every day, you come in and you swing the same sword at the same dragon, and we could do that, and we can't do it anymore. We have to understand where our systems issues are. We need to fix our systems issues so those things go away. And so we're seeing a lot of our hospitals use the Just Do It's for that.
So that's what we're using. So we're using denials. We have a denials management team that we've started, and we're tracking each physician has denials and a dollar amount tied to, you know, if they order something and it gets rejected, that dollar amount is tied to their performance. And so now what I'm going to have Kelsey working on is drilling down to the root cause of the denial and going back to the practitioner so it stops happening. And those are the things that she's talking about, you know, how to manage that. That's what we'll be working on.
There's a lot of money that lives in denials. There's just a lot of money that lives there, right? And all those kinds of things for us right now. And the time. Every time we get a denial, somebody has to work the denial to see if we can get paid. We can do something to it to get paid. So if you make all that time go away too, all of a sudden you got a whole lot more manpower to invest in other things. So, well, again, I just want to congratulate you all. We had a great DMV survey. We had a great risk management survey. You should be very proud of what your hospital has accomplished and will continue to accomplish.
Well, thank you, Darlene, thank you for your
Thank
help.
you for sharing with us and thank you for helping us. All right. You leaving?
He's melting.
Next item is the CEO's report. Candace?
I'll make mine really quick. I told Darlene she could have my time. Just wanted to let you know, as far as where we're at with Dr. Tupper, he does have a surgery date scheduled in July. I think it's the 18th or so, 18th or 19th. He's got some procedures scheduled. Be careful, Darlene.
Thank you.
So excited to get started on that. Employees, or the staff in the surgery department, they've been getting in their equipment that was needed, and so really excited to get started with Dr. Tupper and his crew. Did you have anything specifically from my report that you saw you wanted me to visit about? Or would you like me to be quiet so you can? Okay, I figured so. Really, that's all I have. Was in my report, nothing new.
Okay. Any questions for Candace? If not, I would entertain a motion.
I make a motion to approve the CEO's Share Medical Center written report for June 20, 2023.
Second.
I have a motion by Jay Randall, a second by Dr. Hannaford to accept the Share Medical Center written report for June 20, 2023. Roll call vote, please.
Hannaford?
Yes.
Randalls?
Yes.
Brown?
Yes.
Bowman?
Yes.
Gaston?
Yes. Next is the CFO's reports. Angelica.
Try to make it quick since it's so hot. Our cash position increased this month to $116,000, which is about 3.2 days of operating expenses. We really worked to get some support in for our coders so we can decrease our unbilled AR and work to decrease our AR throughout the month of May as well. Working on, so I apologize. With that decrease in our unbilled, it's helped stabilize our cash flow just a little bit. We're working to get our AP paid down. We are at about $857,000 for outstanding AP at the end of May. With cash flow stabilizing just a little bit, we're working to get that paid down and continue to keep that a little bit more consistent. Our gross patient revenue was at $1.8 million at the end of May, which is an increase of $115,000 over the month of April. Year to date, we're at about $18.5 million, which is an increase over 2022, and also if you're looking at pre-COVID numbers, also a small increase over 2019 as well. Operating expenses decreased about $173,000 from the previous month. Year to date, we're sitting at $12.3 million. Well, this is an increase over last year, which we have been anticipating. We've had a slight increase in salaries, professional fees. We've done a lot of work with Orbis this year, and then other one-time expenses in purchase services in preparation for our implementation of Medicare Expanse. So we should see that go down in the next year. Year to date, or excuse me, for the month of May, we had about $13,000 gain or net income, and year to date we have about a $670,000 loss. So we are sitting a little bit better than we were in fiscal year 2019, which was pre-COVID. And we did have a good month for 340B revenue. I wanted to point out here about $70,000 in 340B revenue for the month of May. So we consistently over the last quarter have been at $70,000 or better a month for 340B. So when we get the finalization of our RHC for the downtown clinic, we should also see a continued increase in 340B revenue there as well. What questions can I answer for you all about the financial statements?
Any questions? If not, next item is the budget.
So if you'll look towards the end of your financial statement section, we have the proposed budget for 2024. Looked at a combination of things, looked at some historical figures, how compared to last year's budget and what we anticipate for next year. So we've budgeted for approximately $22 million in gross patient revenue. It's a little bit above where we are at this year. Also knowing that we've got our general surgeon on board and moving forward, and our orthopedic surgeon on board, and getting the scheduled procedures, so we're anticipating seeing an increase in revenue there for outpatient revenue for surgeries, also for labs and radiology as well. And also physical therapy potentially with the orthopedic surgeon. So I feel a somewhat conservative increase in revenue for that. Hopefully we will continue to increase the patient count there. For our total reduction of revenue, basically looked at historical figures there and used similar percentages to previous years to kind of estimate what our contractuals, bad debt, and charity care will look like for fiscal year 2024. Other operating revenue, based on this year's cost report revenue and our 340B revenue, that is where we're gathering our information for our other operating revenue of about $1.685 million for next year. Salaries, I'm not going to walk through all the expenses. We try to keep our salaries fairly consistent with where we were at this year. And FICA and benefits are a percentage of the salary expense there. Keeping our insurance and professional fees somewhat consistent with where they were at this year. We did have a slight decrease in professional fees to account for, we've been working with Forbes quite a bit over the last year and don't anticipate having to have quite an outlay of cash for those services going forward. We're been through quite a bit with them and should see a decrease in expenses there. So supplies, we kept consistent with this year. Apologize. And then other expenses, we do have a slight increase in our other expenses, anticipating just some upcoming changes in Meditech, with Meditech. We know we're going to have to do some data archiving and just some other things to kind of clean up the implementation process. And so then we should see those expenses go away after next year. What questions can I answer for you on the budget?
Finance, we had a special meeting where we just met to do the budget, and then we touched it up a little bit yet today. Probably the one area that could still have maybe some growth, but it just hasn't been trending in that direction lately is your inpatient. But outside of that, everything else was pretty well aligned with what we had done. Is there any questions about it?
I make a motion to approve the fiscal year 24 operating budget.
Second.
We have a motion by Jay Randalls, second by Dr. Hannaford, to approve the fiscal year 24 operating budget. Roll call vote, please.
Randall,
Yes.
Brown,
Yes.
Bowman,
Yes.
Gaspard,
Yes.
Hannaford.
Yes.
All right. Next item is the Medical Staff Executive Committee. Is there anything to report from med staff?
Nothing of note. We do have some credentialing that needs done.
Okay. So So under credentialing, the first one is to reappoint to Percy staff Reggie Pappy, MD. That won't be telecardiology, that'll just be cardiology.
Correct.
Make a motion to reappoint to courtesy staff Reggie Pappy, MD.
Second.
I have a motion by Dr. Hannaford, a second by Greg Bowen, to reappoint to courtesy staff Reggie Pappy, MD, cardiology. Roll call vote, please.
Brown,
Yes.
Bowman,
Yes.
Gaspard,
Yes.
Hannaford,
Yes.
Randalls.
Yes.
And the next item is to appoint to courtesy staff Joel Tupper, MD, orthopedic surgery.
Make a motion to appoint to courtesy staff Joel Tupper, MD. Second.
We have a motion by Dr. Hannaford, a second by Greg Bowen, to appoint to courtesy staff Joel Tupper, MD, orthopedic surgery. Roll call vote, please.
Bowman,
Yes.
Gaspard,
Yes.
Hannaford,
Yes.
Randalls,
Yes.
Brown.
Yes.
All right. Thank you, everybody. Anything for Quappy? Other than what we already heard? Nope. Next item then is improvement to patient care. Should have back under one of those tabs.
7 reviewed and all over 100%. Some policy and procedures review, and doesn't look like there's any notes. They were all just reviewed, not changed.
So that's the one that requires us to have a vote. And so I need an approval or disapproval for the revisions report dated May 31st, 2023.
Make a motion to approve the revisions report dated May 31st, 2023.
Second.
I have a motion by Jay Randalls, a second by Dr. Hannaford to approve the revisions report dated May 31st, 2023. Roll call vote, please.
Gaspard,
Yes.
Hannaford,
Yes.
Randalls,
Yes.
Brown,
Yes.
Bowman.
Yes.
Okay. And the next item is the medical staff bylaws. Again, those were reviewed, and we have to vote on those each year. Any major changes?
There were no changes, it was just review.
Make a motion to approve the medical staff bylaws and rules and regulations.
Second.
I have a motion by Jay Randalls, a second by Greg Bowen, to approve the medical staff bylaws and rules and regulations. Roll call vote, please.
Hannaford,
Yes.
Randalls,
Yes.
Brown,
Yes.
Bowman,
Yes.
Gaspard.
Yes. All right. Next item is the Share Convalescent Home report. Go back under the Convalescent Home report. Kelly is not with us here tonight. He is somewhere south of here. Is there any questions? Do you have anything to add, Angelica or Candace?
No. You have any?
No, I don't have anything.
At the back of the Share Medical Center Convalescent Home, there's the budget.
And I can talk about that high level. I mean, essentially, we work to just keep next year's budget consistent with where we were finishing out this year's, where we were projecting to finish out this year's revenue and expenses. Very similar. I don't anticipate, I should be where we end up this year, and I feel like it's a pretty good outline for next year.
motion to approve the FY24 operating budget for Sheriff Cobbles.
Second.
We have a motion by Dr. Hannaford, a second by Jay Randalls, to approve the fiscal year 24 operating budget. Roll call vote, please.
Randalls,
Yes.
Brown,
Yes.
Bowman,
Yes.
Gaspard,
Yes.
Hannaford.
Yes.
The next item is the homestead report. Anything to report outside of, or for the homestead? If not, likewise, at the back of that report, there is the budget for 2024.
And we worked that essentially the same way we did with convalescent home. We just kept it consistent with where we're projecting to finish out this year without any significant changes.
And that's based off a little bit less census.
Yes.
At the end of the,
Yes.
Both them and the nursing home, the census is lower than where we were a year ago.
I'll make a motion to approve the FY24 operating budget for the homestead.
Second.
Have a motion by Dr. Hannaford, a second by Jay Randalls, to approve the fiscal year 24 operating budget. Roll call vote, please.
Brown,
Yes.
Bowman,
Yes.
Gaspard,
Yes.
Hannaford,
Yes.
Randalls.
Yes.
Okay, thank you. And Joe, thank you for your time and effort on putting this budget together as well. Kelly's not here. I don't assume we have anything to report on the foundation, other than I did see that we recognized this scholarship recipient.
Yes, Elena Pierce was a recipient for this year. And we're excited about that.
Okay, next item is the St. Andrews report. Clark?
Good to be back. Just by the way, O'Keene does have gas stations and food, just a joke. We do only have one stoplight that flashes, but that's just a joke. So a handful of things, I probably brought too much, but I brought sort of a federal and state political update if you hadn't needed a reminder or topics of some of the things that are happening with, the SSM's got a lobbyist, his name is Jimmy. And so I've got some updates, but we don't want them to open no sweat, but obviously we know the Woodward decision to go with Integris. That was something SSM had pursued. We put in a proposal for that. And so the decision was made to go with Integris, so there will not be an SSM facility for the foreseeable future unless something changes with that. And wanted to say that the St. Anthony Hospital did receive a comprehensive stroke center certification from DMV. And so they put a lot of effort into the stroke program there. You'll also see on Thursday, June 29th, this facility is going to receive a cachet of Girl Scout cookies. The SSM Foundation had a generous donor that decided that every employee needed a box of Girl Scout cookies across the SSM facility network. And so you've been slated to receive some. I don't know if I'll be bringing those up here, but somebody will definitely be there. But they do get picked up at 9 a.m. on Thursday, and then they'll be delivered out to the site. So they anticipate a lot of Girl Scout cookies. But I've
Perfect
clarified,
timing for go live.
there are no thin mints.
Right.
That's what I've been told. So I've heard there's no thin mints in the bunch. But so don't prepare yourselves for that emotionally. Physically, if you need to, but you're about to get a truckload. A couple things from the political side. So I want to mention Jimmy's efforts. And so I'm sure you've talked about the gap funding for the $200 million that was allocated as part of the ONCA $600 million spend package that the legislation clawed back. Jimmy and SSM requested two bills that they pushed through. One was $250,000 for the inhaler program. We talked about that before, but that was approved and pushed through. The other one is a $200 million really gap funding. You know, the managed Medicaid program was awarded. If you talk about that, I don't need to mention it, but so there's going to be a lapse between kind of getting to that 90% of commercial rate and where we are now. And so Jimmy's efforts was to really allocate $200 million that will go back to critical accesses to offset any losses and prop up those hospitals. One of those earmarked items was for the enrollment in HIE. You haven't done that yet already. The deadline is July 1st. It was supposed to be, all providers in the state were supposed to get the requirement unless you requested a waiver. The fee was, had a comma in it from what I was told, and so now I think they've dropped that, and they're supposed to pay that fee with this $200 million earmark from the state. So it's good news because we all knew December last year, the SHOP funding hospitals received about roughly $50 million back from the state. Now about $200 million or so will go back to the critical accesses that were, those facilities were excluded back.
Do we have any idea yet when?
I don't know. I know Keene, I was dragging my feet because I didn't want to write that check just to enroll in the state HIE. If you're familiar with HIE, the Health Information Exchange. And so I didn't want to do that over Keene, so I had filed, I had no choice but to write the check. We don't know, we haven't had clarification that I've seen about when the $200 million will be divided and allocated into different funds and things like that, but it's pretty hot off the press right now that the $200 million will be earmarked for that, as well as many other things, but I don't know the amounts. But I know when we do, I'm sure it'll be a pretty resounding excitement across the state for facilities like ours, so that'll be really exciting. And that company is what, My Health Access Network. Have you enrolled in that?
So,
He's requested.
yes, we have, and we're working on that, so with our expanse project going live on July 1st is perfect timing, but they've been hard to get hold of, like to work with.
Yeah, I know it was a survey monkey. That was the form I filled out, which I thought was kind of strange from the state, giving the survey monkey to enroll.
Yes.
Not my show, they just participated. And a couple of things, OHCA, like I said, they selected their Medicaid managed care companies. Complete Health will do a contracted entity for the children's specialty program if you have that population here. OHCA also is returning the requirements to the HIPAA compliance for telehealth platforms. That deadline is August 9th. So no more kind of the bad habits we picked up. Remember the FCC grant that we got to purchase iPads and tablets and laptops to promote telehealth? Well, a lot of that's being scaled back now for HIPAA compliance, and the iMessage feature has to be done through secure platforms to ensure that deadline to convert back to that, and it'll be enforceable, will be August 9th. And then I'm sure you've talked about the vaccine mandate at the federal level, which rescinded on the 31st. And then Medicaid, the CMS is rolling out a lot of guidance for the Medicaid disenrolled, for the provision when the PHE expired, the provision that re-enrolled eligible members into state Medicaid programs ended. And so there's roughly, terrible numbers, they say it's not really accurate, but it's somewhere in the million member mark right now of people that have lost coverage through Medicaid because of what they're calling procedural reasons. They didn't fill the paperwork correctly, or didn't submit paperwork in time. People that would be eligible for Medicaid not filling out the paperwork correctly, they're estimating about 1 million people that are excluded from that. So we're rolling out a lot of guidance to people and providers like ourselves that do care delivery and trying to find more eligible members of our communities that can participate in Medicaid. So that's all I have for my system.
All right. Well, thank you. Thank you for sharing. Next, Greg, council report.
Okay, other than the routine business, there's a couple of things here. The city has set up a seasonal truck route for the wheat harvest. It will be Oklahoma Boulevard, you would go to 281 or Skyline Drive. So I venture to say this north-south route is going to be pretty busy. The road back over there. And then it goes down Santa Fe Street, so the idea is no trucks will be going through town. We'll see if that works. Anyway, the runway lighting project did finally get funding, so we're going to have runway lights again. And I guess the biggest one to this committee is the Homestead Pond bid was I won't say it was rejected, it was tabled because of an agreement between the city and the homestead on how the building is something, and I don't know anything about that paper. Does anybody here? Because I
thought we had inside and outside.
Yeah, as a rule.
I mean, I've never seen the document, so I don't.
I think the bigger issue was a lot of the council members thought the bid Because they only got one bid back and it was high, they all thought.
$11,700.
I thought the liner had been purchased.
It had been, but it sounds like you're talking to Kelly, the contractor that the city originally contracted with could not locate the liner. Would that be a fair assessment?
Yeah, so I guess.
Okay, can we go back to, what did you say before that?
The agreement.
No, before what were you talking about before the homestead?
The
Sorry.
truck route,
No.
the runway lighting.
The runway lighting, thank you. When is that scheduled to start?
That's the thing they don't know. Some of the grants, the contractor has been voted on, so we do have a contractor. Some of the grant money is still a little bit in flux, but this contractor can start ordering parts.
That does affect our patient, like if we need a plane to come in after daylight hours to transfer out, we can't do that.
The way it's saying, everything is, can we get the stuff? It's
Yeah,
kind of what I was taking. So
Just interested in when that is going
there
to
wasn't an answer on that.
Okay.
But anyway, the homestead deal was put on hold until some papers get signed.
The agreement,
The agreement.
I guess we're negotiating the agreement at some point.
Well, wait,
So,
was,
the city requested that be renegotiated last August, but then that was put on hold until they found a new city business manager. And we've had some high-level conversations with the consultant that the city had hired, some tentative conversations, how do I say that? And then I think
September, I think that was.
September, October, and then it was determined that once the new city manager was in place, we would revisit those conversations, but we've not been notified of any additional conversations needing to take place.
or was there you said there was a question about whether or not
No, I
whose
think
responsibility
the
it was.
pond was tabled for some reason. There was,
One of the council members was concerned with a pending contract negotiation, agreed to put money towards the pond when they didn't know what would come of that contract negotiation. And he didn't, I don't think he had any more information on that, but that was his concern, if there was a pending, but the mayor wasn't at the meeting to elaborate on that.
Including who might pay for it? Or where the money would come from?
Right.
Well, we've been trying to work to get that pond letter installed for at least 3 years now, so
long time.
And I think so partly tabled because of that, and partly tabled because they thought the bid was high.
Well, everything's coming in high.
honestly, if that contractor's got to put a new liner in, that's probably not too far off.
And I think on that bid, a big portion of the bid, of what we received back, was for the mobilization because this company was out of Texas, so they didn't have anybody from Oklahoma who came in and did the projects.
So anyway, no news, pond's not gonna happen this year. That was about it. Executive session.
All right, thank you. All right, next item is the chairman's report, and we have election of officers each June. We elect officers for the next fiscal year because we operate July 1 through June 30th. Currently, I am chairman, Bo is vice chairman, and secretary is Kayla. So, first, chairman of the board.
I'll make a motion to elect or nominate Jason Gasper as chairman again.
Second.
Which one of you is second? Greg?
Could be Matt both.
I'm just writing down whose names I need to contact. We have a motion by Dr. Hannaford, a second by Greg Bowman, to elect Jason Gasper to be the chairman of the board. Roll call vote.
Bowman?
Yes.
Gasper,
Yes.
Hanford,
Yes.
Randall,
Yes.
Brown.
Yes.
Very enthusiastically. All right, next item is vice chairman.
I'd make a motion we elect Dr. Bo Hanford as vice chairman.
Second. Have a motion by Jay Randalls, a second by Greg Bowen to elect Bo Hannaford as the vice chairman. Roll call vote, please.
Gasper,
Yes.
Hanford,
Yes.
Randall,
Yes.
Brown,
Yes.
Bowman.
Yes.
Next is secretary.
And even though she's not here tonight, I make a motion that we elect Dr. Hayla Simon as secretary.
I'll second.
Yes.
Yep.
We have a motion by Jay Randalls, second by Dr. Hannaford to elect Ayla Simon as the secretary. Roll call vote, please.
Hanford,
Yes.
Randall,
Yes.
Brown,
Yes.
Bowman,
Yes.
Gasper.
Yes. The only other thing is a reminder, next month, we will not have a board meeting, so our next scheduled board meeting is August 15th. Never mind, that's finance. Look at the wrong one.
Jason.
August 22nd. I was thinking, man, that was awful quick. August 22nd. Anything else? If not, we are adjourned.